Welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy and the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsors and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. Cal Mesa is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by Cal Mesa are funded by counties through the voter-approved Proposition 63, the Mental Health Services Act. The Agency for Healthcare Research and Quality, Academy for Integrating Behavioral Health and Primary Care, functions as a coordinating center and national resource for people committed to delivering comprehensive integrated healthcare. The Academy focuses particularly on integrating behavioral health care into primary care practice and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders. Key Academy tasks include the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated healthcare, the Academy web portal and literature repository, and the recently developed lexicon for behavioral health and primary care integration. The Collaborative Family Healthcare Association is a nonprofit, member-driven collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. The Advancing Care Together project at the University of Denver Department of Family Medicine is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program is funded by the Colorado Hogg Foundation and focuses on 11 demonstration projects that have been organized as a set of diverse comparative case studies that will be linked to support cross-project learning. Before introducing our presenters for today, I would like to quickly just go through a few housekeeping items. To listen to the audio of this webinar, you can listen through the telephone by dialing into the webinar and PIN ID showed in the webinar control panel, or use your computer, mic, and speaker. All participants are currently muted, but if you have a question, you can either click on the little hand raise icon and I will unmute you, or you can submit it through the chat feature. And that is in your GoToWebinar control panel towards the bottom. Today we are pleased to bring you Drs. Chapa and Sanchez. Dr. Chapa is a Senior Policy Advisor on Mental Health at the U.S. Department of Health and Human Services, Office of Minority Health. Dr. Chapa leads behavioral health integrated efforts initiated aimed at eliminating disparities in mental health and substance use among underrepresented and underserved racial and ethnic minorities and limited English-speaking minority populations. As a member of the senior leadership team, Dr. Chapa works to ensure that behavioral health is part of the public health agenda. Dr. Katherine Sanchez is an assistant professor at the University of Texas Arlington School of Social Work. Dr. Sanchez practiced as a bilingual clinical social worker for 15 years, primarily in medical settings with monolingual Spanish-speaking populations. Her principal area of research is in integrated healthcare and the provision of sociocultural, linguistically adapted models of treatment for comorbid mental and physical illnesses. Today, our presenters will discuss the delivery of integrated healthcare to racial and ethnic minority populations based on a collaborative model led by the U.S. Department of Health and Human Services, Office of Minority Health, and the Hogg Foundation for Mental Health. Please welcome Drs. Chapa and Sanchez.
Thank you so much. I'm going to go to the first slide. I just want to say thanks to Emma and Gilchrist and Ben Miller and all my colleagues, our colleagues at ARC, at the Hogg Foundation, and of course to my colleague Katherine Sanchez for working on this and inviting us to do this very timely webinar. So next slide, please. So why is this so important? Let's look at this population chart and get a sense of like what's happening out in the world, like in our country here. And basically, even though you can see that those persons who state that they are white alone and not Hispanic are at 63%, we really have a growing trend of quite a large movement of racial and ethnic minorities moving towards equal to maybe majority status. For example, The population that's 1 year and younger is over 50% right now. And the population that's 5 years of age and younger is at 49.7%, just shy of the majority. And a minority majority population is a population that consists over 50%. So really our population, the minority population, is everybody's population and vice versa. We're going to be just everywhere and a part of every setting. And so it's timely that we really look at this particular topic. Next slide, please. So let's look at the health challenge. You know, our current health and behavioral health care, we know this, but we just want to set the stage here, is really set and fraught with barriers, even now, even after reports have been written 10 years plus ago. And even though a lot of good work is being done, we still are fraught with behavioral health conditions, and we know that consumers die prematurely to preventable physical conditions. And we also know that behavioral health issues are among the very most expensive to treat. And even though the paradigms are changing as we speak, we're not quite there yet. Next slide, please. Next slide. So here at the Office of Minority Health, our mission really is to improve the health of racial and ethnic minority pops. And as you see here, it's through the development of research, demonstration, and evaluation, improving awareness, working on data. In fact, we were heavily involved in the data under the Affordable Care Act, and kind of working on policy briefs to define what racial and ethnic minority populations are, and developing partnerships and networks, etc. And I wanted to let you know a little bit about why we're involved in our particular and special role in integrated care in our efforts to eliminate health disparities. Next slide. So fitting within that mission, I'm very excited to say that it's been 10 years in the making that we've been involved in integrated care. And, you know, we kind of piggybacked off some of the recommendations that came out of the New Freedom Commission, and created a National Minority Health and Substance Abuse Leadership Committee that kind of dealt with integrated care in order to not just look at approaches to care, but how to address behavioral health gaps for our communities. And that really began with an issue brief titled Mental Health Services in Primary Care Settings. And you see the title there, and that came out in 2004. And we were asked to brief the Office of the Secretary. After that, it established an integrated care focus group. And I want to give credit to our minority behavioral health leaders out in the field across the country that really pushed this at the Office of the Secretary level and made this happen. So very exciting. Next, please. We go to Katherine. That was quick.
Thank you, Teresa. Good afternoon, everybody. Thanks for joining us this afternoon. I'm going to give a little bit of the research literature and background to the work that SNI and the Hogg Foundation did together. And the research literature that I reviewed and that we worked on together to come to some agreement about the concerns. So in 1985, the U.S. Department of Health and Human Services first described persistent, significant health inequities affecting racial and ethnic minorities in the United States. Racial and ethnic minority populations are less likely to receive a variety of medical services, from routine procedures like appropriate cardiac medication and bypass surgery. On the other hand, and in more extreme situations, racial and ethnic minority populations are more likely to have limb amputations as a result of diabetes and just experience a lower quality of health services overall. Racial and ethnic populations are also less likely to see a behavioral health specialist, which I'll go further into in a minute. And all of these findings for racial and ethnic minority populations held even when controlling for insurance status, income, age, and education level. This is strictly a function of being a racial minority in this country. So race and ethnicity alone predict lower use and lower quality of healthcare. So fundamentally, the top 10 causes of death and the top underlying causes of death disproportionately affect different groups. Next slide. So this is a different kind of population map. This is the distribution of the uninsured population in the United States. And if you recall from Teresa's earlier slide, only 16.9% of the population is Hispanic. However, you can see that 32% of the uninsured population is Hispanic. Similarly, African Americans make up 13% of the population, but represent 16% of the uninsured. All told, half of the nation's uninsured are from minority communities. Next slide. We're all familiar with the notion of the primary care system as having become the de facto behavioral health system. But we're going to talk about how this is different for racial and ethnic minority populations. There is a lack of access to behavioral health specialists in general, but there is also little to no knowledge about mental health services among racial and ethnic minority communities. And in those communities where they might be informally communicating about mental health services, there remains persistent stigma around mental health and mental illness. When people do access services, there is significant, what's been described in the literature as poor doctor-patient communication. Much of that has to do with a lack of access to in-language or linguistically appropriate and culturally appropriate services. And of course, there are income and insurance differences. So there are really, what we're talking about are system level issues that have something to do with provider shortages and particularly kind of in language and culturally appropriate services that need to be addressed at a system level. Next slide. So as a result of these inequities and these system issues, racial and ethnic minorities across the board receive delayed treatments. They receive evidence-based interventions at a much lower rate than the general population. They experience what's been described as poor treatment engagement, so they're not likely to get kind of hooked into services even when they seek them. They're far less likely to follow through with a referral to a behavioral health specialist. We know that when people go to that trusted relationship of the primary care provider to discuss some of these very stigma-laden issues, even when that referral is sort of put in place to follow up with a behavioral health specialist, the people are less likely to do it. When they do go, they are far less likely to receive evidence-based interventions. They're less likely to receive accurately translated screenings and assessments. Even some of the state-of-the-art psychotropic medication is not provided. Racial and ethnic minority populations are much more likely to discontinue treatment without consulting their provider. So really the message here is that accurate screening, diagnosis, and treatment of behavioral health disorders is entirely dependent on a linguistically accurate interview. If we're not even screening people or assessing people on the front end in an accurate way, we're not likely to get to the heart of the disorder, leading to dissatisfaction and probably less follow through with treatment. Next slide. Many of us know the data around persistent and serious mental illness. People with serious and persistent mental illness are dying 25 years earlier than the general population. That increased morbidity and mortality is largely due to very treatable medical conditions that might be modifiable risks such as smoking, obesity, substance abuse, depression, and often people think that that number 25 years earlier is driven by trauma or injury related to issues such as homelessness or intoxication, so sort of a different kind of lifestyle issue. But that's not true. In fact, 60% of those premature deaths in people with serious and persistent mental illness are really due to what we call natural causes, right? Natural causes in quotes. So, you know, as I'm preaching to the choir when I say overall health is essential to mental health. So we got to be addressing people's physical illness as well. And recovery is, of course, possible. Next slide. Recent public health efforts, particularly in the last decade, have identified a select array of conditions in which people live that are significantly affecting their health. These are referred to as the social determinants of health. And really, we're talking about the inequitable impact of the environment and social conditions in which people live that has a significant effect on the persistent and pervasive health disparities that are plaguing racial and ethnic minority populations. Those social determinants are described as their socioeconomic status, racial segregation and living conditions, where you live, even just the neighborhood that you live in puts you at greater risk for bad health. Certainly occupational risks and exposures, health risk and health seeking behavior, differences in access to care, and then the quality of care when it is accessed. These are what are known as the social determinants of health. Next slide. Galea and colleagues did a study in 2011. They looked at data from folks that died in 2000, so it's 14 years ago, but this is all still very persistent today. And what they did was they looked at the death records of hundreds of thousands of people, and they went back into their lives, their social lives, and looked at education level and where they lived and their supports and their income. And the social determinants that are attributable to increased death rates included low education level was at the top of the list of what contributed to the death rates. Racial segregation, low social supports, and poverty all added to were sort of directly linked with cause of death in racial and ethnic minorities. So these social determinants are thought to impact health indirectly through their influence on health promoting behaviors. Racial and ethnic minority populations are particularly likely to live in conditions that put their health at risk. This has a lot to do with sort of health literacy issue and even kind of health promotion behaviors and things that put people at risk for poor health. Next slide. Lack of English fluency, which is also referred to as limited English proficiency, is an independent predictor of poor control of chronic disease, reduced healthcare use, poor quality of primary care, an absence of a regular source of care, lack of continuity, lack of satisfaction, poor quality patient education and an understanding of their disorder. Simply not speaking English or having English, having another language as your primary language puts you at greater risk for bad health outcomes. This is why language concordance or an appropriate language interview is essential to providing good quality care. Next slide. Other factors that affect access to healthcare for immigrants and minority populations include health literacy, which I mentioned. There's obviously some geographic inaccessibility. A lack of medical insurance has been huge and frankly will continue to be under the Affordable Care Act, largely to do with citizenship status issues. There are acculturation issues and just the time that you've lived in the U.S. Predicts whether you access care and the quality of care that you might receive. Next slide. It's going back to Teresa.
All right, thank you. I also wanted to add that some recent literature is coming out about trust issues and applying for the Affordable Care Act. So there's a lot of work for us to do at the community and local levels in gaining trust and encouraging our community members to get registered for health insurance, those who can. So a couple of years back, in response to the lack of literature on integrated care, particularly relating to racial and ethnic minority populations, the Office of Minority Health approached one of our partners, which was the Hogg Foundation for Mental Health in Texas, and many of you know them. And they had been doing quite a bit of work on integrated care earlier on. So we thought this was a good group to discuss some of our concerns with. And we came up with some goals, basically, of how to bridge that gap. I mean, we are very concerned. We've had EPC reports by our sister agency ARC and other research abound across the country with very little either looking at racial and ethnic minorities as patients or consumers, or maybe collecting those data and not analyzing those data, or whatever the factor may be. We really weren't looking at any key elements that related to our minority populations, and we're very concerned about that, particularly in moving forward. So we entered into a cooperative agreement with the Hogg Foundation, and the goal or objective was to identify and recommend cultural and linguistically competent elements, strategies, practice innovations to be incorporated into models and approaches for integrated care, particularly when being delivered to our communities and including the limited English proficient community member, as well as to identify effective strategies for implementing changes and to create new knowledge base for this paradigm. So we're really starting scratch in essence. And I have to say that it was a tall order, but a very exciting order, and very willing partners who I feel did an excellent job. Next slide, please. We immediately assembled a core project advisory team that could move this initiative forward, including looking for a science writer, and it was a competitive process, and Dr. Katherine Sanchez won that process, so we're very lucky to have her. And what we wanted from that were some key elements, and that's a literature review on integrated care for our communities, and that's available now, thank goodness. An examination of the role of language and cultural and linguistic competence, convening of an expert panel, the development of a consensus report, and dissemination and training, all which have occurred. Papers are out there and abound with an upcoming publication, as well as what I call filling in the gray literature with information that was never compiled before. So very excited to be able to make this available for all of you. Next slide, please. So this is what actually the consensus statement report looks like, and again, it includes all of those elements I just discussed. And I invite anybody to, download that and take a really hard look at the work that's behind it, including the lit review. That's a complementary compendium, and the recommendations, which we're going to cover in brief at the end of this presentation. Next slide, please. So getting back to what we call meaningful access, which is really language access as well as quality, we have found through our literature search that really improvements in meaningful access alone make a difference. And so we're looking to improve access and the quality of behavioral health care, and know that that alone could potentially eliminate health disparities. And there's a bit of research behind that that's been out for the last 6 to 8 years, but very small studies. So working with the Hogg and compiling that work has provided us this excellent background. So some of the components are promoting best and promising evidence-based practices that are cultural and linguistically appropriate. I'm sorry to say that this particular webinar will not go into depth around CLC, but we have offered those particular webinars in the past, and perhaps in the future there can be more. It's basically to just give an overview of how to incorporate these particular components. Secondly, encourage implementation of integrated primary and behavioral health care models. Third, support efforts to build multidisciplinary and diverse, knowledgeable, bilingual, and culturally competent workforce. That's a mouthful, but really it means, some people will say bicultural, bilingual, culturally competent. We need all of those particular strengths and qualities in our workforce so that we can reach the individuals that Katherine so eloquently discussed prior. And also the Affordable Care Act as a possible way to at least grow our coverage and deal with some of the insurance issues. For those who are uninsured, we do have our fairly qualified health centers and they are now required to include behavioral health. So little by little, we're getting to that scene. And improve information and science dissemination strategies through efforts like learning collaboratives, such as this one, so that we can expand our knowledge, share our knowledge, and not duplicate the wheel, but improve upon that wheel. Next slide, please. Other components would be to respond to the current and projected demographic needs. So as we showed you earlier, our population is grown. I don't like to say that it's growing, it is growing, but I think we're really there, and sometimes we have a discussion in the community or even online and with our colleagues that, you know, we really got to get on this because minority communities are growing, and I'm here to say today that we're here and we're broad and we're big and ready to take leadership and also be served. We really do want to promote this elimination of long-standing disparities in health status for our communities and improve quality of services and outcomes, and to meet legislative, regulatory, accreditation mandates. So these are all reasons why to incorporate cultural and linguistic competence and to create a behavioral and physical integrated care setting that reaches our communities. And also, just to be practical, really, it's to decrease the likelihood of liability and malpractice claims. So if we're working with people that we're not understanding what they say, particularly because of differences in language, it really does put the patient and us as providers at risk. Next slide. So because the workforce is really not as robust as we'd like for it to be, I'm going to go over some. Actually, let me back up and say these are some of the findings from the group in the consensus and the paper. But it's really, this particular part is because we really do need to build that workforce, and also consider looking at how we deliver in our systems of care. So it's really important to look at those administrative policies, job descriptions, performance reviews, confidentiality agreements, and care coordination practices, as they should really reflect cultural competence in our integrated care practices. So this is really challenging each and every one of you and all of us to notch it up a bit and not have a parallel process and say, hey, we're going to do this afterwards, or these people down the road are going to do it, but to incorporate it into your general practice. It's also to establish a change team that will influence culturally competent integration. So bring together a small committee, just like we did to create this process, and they can be the leaders of that change in your organization. Don't change it yet. Also consider a team composed of senior leaders, program directors, and consumers from all of your organization's service areas, so that you know that the community's voice is included. I know that this occurs at the FQHC level, but not necessarily in a lot of our other practices. So we as a team really made that as a premier recommendation. And finally, look to develop organizational expectation, workflows, job description, performance review, language quality, improvement benchmarks. So what this is really about is accountability. So when we say we want to incorporate cultural competence and make our particular delivery system one that can reach out to racial and ethnic minorities and those with limited English proficiency, it really does require these components in order to create a solid system of care. Next slide, please. We call this one a paradigm shift 2. So strategy 2 is the organization's strategic and business plans should also reflect cultural competent goals as a priority. And again, you know, if you don't state it, it's not there, and people don't feel that they need to be accountable to those goals and objectives. And look at technology as a way to be able to enhance sharing information, maybe use some of the online trainings around cultural and linguistic competence, but really have those components in place and in your plan so that anybody can review it and be and know that it's an integral part of your agency. Next slide, please. And this is our cultural linguistic competence paradigm shift 3, which talks about clinical workflows. And really, we must be clear and consistent in what we're asking for. For example, are you monitoring to ensure that your primary care and behavioral health staff create a person-centered, culturally competent, integrated healthcare plan for each person? So, you know, I know that we're doing that with all of our clients, but we're asking people to take that additional level and incorporate cultural linguistic competence into those plans. And quality improvement is a valuable way to make sure that your staff and your organizations are meeting that integrated care goal in cultural competence, and thus ensuring overall health quality for our clients. Because remember, you know, we really have to be sensitive to all of those social determinants that were mentioned, as well as the fact that we have somebody right there in front of us. It will improve engagement. It'll improve following through with mental health recommendations, even medications, if we have the right team put together and the type of team that is committed to serving all of our clients, regardless of race, ethnicity, and language capabilities. And I'm back to Katherine.
So next slide. We didn't talk too much about process in terms of our consensus meeting and how we went about that process. It's kind of complicated, and you can read about it in the report. But we basically gathered a diverse group of experts, primarily from practice. Some were academic and practice, but all practitioners who work with racial and ethnic minority communities and deliver really good linguistically and culturally competent care. And through a process, we developed a set of consensus statements that were then followed by a set of recommendations. This very busy slide, actually, covers the consensus statements. And really, on the right-hand part of the slide is a kind of a visual representation of the consensus statements that came out of the work group. And so I'm going to talk a little bit about that framework, and we've called it a framework for the integration of behavioral health and primary care services for racial and ethnic minority populations and those with limited English proficiency. And this really was the product of that consensus meeting. The pieces of the framework, each of the pieces kind of represents a different part, one of the consensus statements that came out of the group. So the first is that care is delivered across the lifespan. In an integrated care organization that is culturally and linguistically competent and responsive to the community and resides in a reasonable location that has flexible hours of operation. All of those components of that integrated care organization really are a reflection of the social determinants that I talked about. So putting it in the community in a way and delivering the care in a way that people can actually access care, it helps to address some of those social determinants. The integrated care team is multidisciplinary and cross-trained. Those of you that know the integrated healthcare literature, we have a real problem still with cross-training in disciplines. So even folks that are within specializations getting trained in this model and understanding integrated healthcare, there's still very, very limited kind of cross-training or interdisciplinary training. So we would encourage that to occur at the organizational level, since it's often not occurring at the kind of academic training level. Another agreement is that there be one health and behavioral health history and one treatment plan that is patient and family centered. Some of the language is changing, I think, across the board on the notion of families, of bringing families and other important people in the patient's lives into treatment, but that is particularly true for racial and ethnic minority populations. If you're not talking to the family, then you might as well give up talking to the patient, because this care needs to be delivered in a family-centered and patient-centered way. One treatment plan, I already mentioned, the influence of the social determinants on the location and the hours of operation, paying very close attention to health literacy issues, linguistically accurate interviews, linguistically appropriate screenings. So this is an overall set of consensus statements that the group came up with, and then all together we broke it down, or it was then broken down to specific recommendations at various levels of intervention, which Teresa is going to talk about next. Oh, those are the consensus statements. So the next slide is the consensus statements.
That's okay. Katherine,
you can skip over that one.
Yeah, we just basically posted that for you for your personal notes, so that you'll be able to go to it directly and see what was specifically outlined by the expert panel. So the expert panel recommendations really included 5 areas that needed special attention, and included 1, patient consumer-driven approaches, 2, practice innovations, 3, community action and involvement, 4, systems of care that provide service where service is needed and where the patient and consumer lives and thrives and works, and lastly, workforce development. And we would include community health workers and promotores de salud, or health representatives, however those individuals are titled within various communities. And so I wanted to just say that overall, before I went into some detail, for example, with the patient and consumer page that's in front of you, we really do want to see a comprehensive assessment. And again, I know we're driving this deep, but it has to be done in a culturally and linguistically appropriate manner, so that we get beyond, even beyond just the language, but kind of understanding what's a part of that language as far as beliefs and constructs and how they might inform a symptom profile, because that's so essential for not just from our perspective for diagnosis and treatment, which is essential, but for engaging our consumers and our clients. And we found that in those model settings that have those components of care, that they're able to retain patients in treatment until they're finished with treatment, and they're able to be flexible about how that's delivered. And Katherine also said it very distinctively, and that is that it has to be patient or consumer driven, including family members, trusted persons from the community, whomever the client wants. But in many cases, and particularly for immigrants, it needs to be a family member. Next page, please. I kind of already touched upon this a little bit, but we need to really, in the field of practice for screening, et cetera, develop and share appropriate tools that go beyond standard measurement. A lot of tools that we see, excuse me, are, for example, when the PHQ came out, the PHQ went to various communities, whether it was Hmong speakers, Chinese Mandarin, Filipino, or Tagalog, Spanish, French Creole, whatever. And in these individual settings, folks were just translating these documents or the assessment tools. And our group really recommended that there be like a core group that does this in a bit more of a professional manner. Not to say that our colleagues across the country didn't do it in a professional manner. I think people did what they could with what they were provided, but we'd like to see a little bit more standard operations in place. I mean, this is typically required when you're translating something for American Psychological or for anyone. There is a standard that's appropriate that would include literacy levels, et cetera, for the targeted community. So we want to really make sure that what we're doing really meets the needs of our communities, and that it includes those components that get to what we need. And once we have that, there should really be a mechanism for sharing that, so that we're not rebuilding things and have people in different corners of the country having to come up with this again on their own. So again, through our shared workshops and trainings, putting stuff online. And also building an understanding by cross-training and exposing other individuals to these as well. For example, some particular screenings can be done by community health workers or promotoras or your whomever is assigned in the IC environment. Next slide. You know, just like we mentioned, the value and the importance of family members, communities are extremely important as well, because so many of us, including racial and ethnic minority pops, really live in the community and are part of the community. And so it's real important that we create culturally responsive, strength-based environments that are being tapped into. Create and support and have them inform us as well. Because we do have a lot of strengths in our community. It's not all dire. There's a lot of things going on at the local level where people feel they need to pick up where we're slacking off in some of our care provisions. And we want to make sure that they can become part of our team so that our communities who are seeking care and coming to us do receive the best care available, and we hope that's evidence-based practices. So we also need to look at other types of approaches that maybe are derived from other sources, like community-based participatory approaches, where the community has a voice in that, providing and defining that evidence, and working with people across the country in different communities. This has been a vital component to buy-in at the service level as well. So how do we get some of our minority providers to even buy into some of the evidence-based treatments when, you know, it hasn't really been garnished using some members of our community, and people kind of question the effectiveness? Well, there are different ways that we can bring people in and accumulate evidence, et cetera, and make them a part of that whole approach. We also, I think it's very important to identify and empower leaders from within our community to come and work at our settings, even be that receptionist, be that voice, be that leader with the promotoras, be that provider, be on our board. It's extremely important that there is a voice, a minority voice, a diverse voice, an inclusive voice, in order that we don't continue creating these parallel dimensions of services that right now exist on all levels, by the way, not just in service levels, but research and data, everything. And so we also want to be able to provide that behavioral health education wherever people are in the community. So maybe we can put health information at our, you know, different desks throughout the community, including working with our clergy, our faith-based, and other individuals that are pivotal in the lives of our community members. Next slide, please. And for systems of care, again, provide those services where needed. I cannot stress that hours are essential, particularly because so many members of our community hold 2 and 3 jobs. They're not necessarily available between 9 and 5. And we've already addressed the other issues around cultural and linguistic diversity and evaluating for practice efficacy. So next slide. And this workforce piece is so huge. It's unbelievable, because we already know we have a dearth in practitioners of behavioral health that can come and work in these integrated care settings. And when it comes to health and behavioral health, we have smaller numbers that are racially and diverse professionals, and especially those who speak other languages. So it's really important to us right now to attract and retain bilingual and bicultural providers, or those who are excellent speakers and culturally competent. We want to start identifying and engaging individuals at early stages in their studies and careers, and there's a bit of a movement abreast. But I'd like to let everybody know that it's out there, because sometimes this is only knowledge in the racial and ethnic minority communities. But I'd like to invite all of our communities out there to start taking a stake in these efforts. also to really make it a priority to provide in culture and in language not only treatment but supervision, and to build and support diverse and empowered leadership. So I know we kind of ran through these quickly. There's a lot to cover, from who we are as communities, some of the main disparity issues, social determinants of health, the work that we've done to fill in the gaps and to create the great literature and the peer-reviewed publications, our goals to change how services are delivered and to include various persons from around the country to make them empowered and involved. Next slide. So we do have for you additional resources. They're not all OFSA minority resources. You can find them just by going on Google because of our partner relationships, but please take a look at the additional resources when you have a chance. Is there another page? Mm-hmm. Next slide. And want to let you know that the consensus group was preceded by individual focus groups throughout the country over a series of years that targeted particular populations of interest, whether it be Asian American, Native Hawaiian, Pacific Island, African American communities and organizations, Latinos, etc. And so those individuals really had a more strident voice and tons of input into the work that you see in our publications and in this presentation. Thank you so much.
Thank you so much to both of you. That was a wonderful presentation. We now have about 10 minutes for some questions and answers. So if any of our participants have any questions, please either raise your hand and I'll unmute you and you can ask like that, or you can just type them into the questions box in the GoToWebinar control panel.
We're flexible.
So one question is for providers. Can you recommend any resources to find tools that have been translated and validated?
Yes. Well, it's sort of depending on the topic. If we're talking about mental health, or we're talking about specifically depression, or depending on the particular disorder, many instruments have been translated into multiple languages. The World Health Organization actually has a number of, their website is very, very useful in finding tools and particularly kind of screening and assessment instruments that have been validated in multiple languages. So there's that. Some of the very common and basic instruments like the PHQ-9 and the GAD-7 and some of those particular screenings for primary care also are easily available. You can just even Google that, PHQ-9 and GAD-7 in Spanish, because those have been widely validated as well. Teresa, can you think of any?
Yeah, and I just want to say that this was one of the, just because of this question, this is why we need to have like a compendium of where to go, because there are, everything that she said and all the instruments that she mentioned have been translated and are being used in various settings. So we really need to get that together. They're out there. I don't know of one place where you can just go online and get something that's validated. That's why I think it's a true opportunity to be able to pull this together.
Yeah. Our next question is, what do you suggest organizations do when they have limited diversity on staff but immediate need?
That's you, Tere.
Well, I guess, I go back to asking, why is there limited diversity on staff? I guess first and foremost, you could start with, to be fair, start with getting training on cultural competence. so that you can really start incorporating some of the values that are essential, particularly when you are serving a diverse community. But most importantly, I think it's your challenge really to look to diversify your staff and look for some of those key qualities. Now, I know that it can be difficult in some areas because I co-ran a social service agency in Minnesota. Yet, and even though that was a Latino social service agency, we had mental health services, we had drug court, we had a number of service components that were a wraparound in nature for our Latino community. And I have to say that even though persons may not have been bicultural, that they had in-depth experience working within and with Latino communities, were extremely fluent in Spanish, and so really were able to join with the client in a very meaningful way. So I really challenge people to look for ways to be able to diversify and fill in those gaps.
And just to piggyback briefly on what Teresa said, if there, sometimes partnerships at the university with local universities can kind of at least be projecting into the future. I know your need might be immediate, so therefore it might not satisfy, but so kind of partnering with medical schools, universities, and really looking at those training and workforce issues. And then, sort of what's kind of more and more widely being used is the community health worker model and some of the promotoras that lay people who've been sort of trained and can be trusted to liaison with those communities in a linguistically appropriate way. So again, it's going to still require some investment on the part of the organization. We don't recommend that community health workers go unpaid or are used as volunteers. We recommend that they be treated as professionals and colleagues. So that's another way to go as well. Anything else?
We have a few minutes left if you'd like to ask any questions.
If not, Emma, I'd like to say a few words.
Oh, sure. I'll let you know if any questions pop in while you're speaking.
Okay. This is Teresa, and I'd really like to make this a call to action to each of you, understanding the diversity around us and the current profile of our communities in which we live, and that you really consider looking carefully at how we build workforce, how we're inclusive, how we collect data, how we analyze data, how we are inclusive in research, etc. And if you look at the Hogg Foundation, they are actually doing quite a bit of work in supporting fellowship for those who are bilingual and bicultural. And I think now, Katherine, isn't it true, in a couple of languages? And paying for people to get their MSWs, and then those individuals in return work in the communities, etc. And so I think it's really time that we do partner across the board using our foundations, local government. I mean, look at California. You have the Mental Health Act. Starting to get creative in how to build that very important workforce and really provide that adequate service. And now is the time, because you see the numbers, you see the ages of children, you see the language issues and the cultural issues, and we really want people to feel comfortable in coming into our settings and utilizing them in the appropriate way. Of course, we want that across the board, but when I say across the board, I mean racial and ethnic minorities as well.
Thank you. And we did get one more question.
Okay.
What steps can organizations take to address and change stigma around mental health services among different cultural groups?
Do you want to try, Katherine?
Sure. I mean, I think that some of the stuff that Teresa referenced, and also the OMH website for where the the cultural and the standards really kind of is an approach to learning how to be culturally competent. And so the first step in reducing stigma is becoming a provider of trust. And in order to become a provider of trust, you have to get into the community and be in the community. So part of like the model that the framework, where in the framework we talk about being there, being present, be available. But we know that historically, even when you're there right in the middle of the community, speaking the language, offering culturally competent services, there's still tremendous stigma I mean, I've had patients and clients tell me that they were afraid someone would see their car at the clinic. So this is huge. This is something I think probably even as a nation we struggle with, probably as a world. But I think that all starts with trust. And again, I think the community health worker model and the promotora model, where you can have members of the community that are trusted members of the community to liaison between the agency and the community, is immensely helpful. Certainly things like non-traditional services I covered in the report. Even in some of the African American communities, they started doing outreach to the barbershops. So just really beginning to think about things in a non-traditional way, so that because you might not immediately be able to get people to change the way they think about mental illness, but you might be able to get them to change the way they think about you and your agency. And so that once you become someone who's immersed and trustworthy, then maybe you can start the conversations about some of the suffering that's going on that people are afraid to talk about.
And I might add also that those are excellent points, pretty much cover the field, but you know, it's really approaching it from a public health model as well, and she gave a great example of barbershops and so forth. But we really do need to include our clergy, where people go. And that's what integrated care is all about, in my opinion. And so we look at clergy, family, friends, those community trusted individuals. I've been asked to meet with families who are coming together just for health education and to come and talk about depression. So do outreach and education. And so there is that other component that's not maybe traditionally a part of primary care, but it is a part of public health. And so that's the additional layer to, I believe, to eliminating stigma and actually reducing it, because we're neutralizing it. Depression is, what's the difference from that or having diabetes or whatever? You need treatment. You need to see someone. You need to be part of a care plan. So I would recommend that as well. That's why integrated care is good, because I think you were talking about people not wanting their car in front of a mental health clinic. Well, they're in front of their primary care doc's clinic.
Exactly.
So, and that's what we've seen, that the majority of racial and ethnic minorities get help or land in the laps of the primary care physician. And we're not talking about emergency, et cetera, because that's the next step, but rather than going to the mental health clinic. So that's why this is so vital.
Wonderful. Well, thank you so much for your time today and the presentation, and thank you to all of our participants who joined us. Have a good day.
Thank you.
Thank you.